Hello, I'm Dr. Craig Stern from Pharma Pharmaceutical Consultants. We've spoken several times about utilization, or effectively the number of prescriptions that a patient receives and how do you measure that, what does it mean. I want to step back for a minute because I think we need to clarify and to address utilization from the standpoint of a health plan, of a physician group, etc. How do you go about monitoring and managing utilization? And in this particular regard, patients are taking whatever medications they're taking, they're using whatever they're doing, and the question here is, are we using medications correctly? Are we using them in an appropriate way? The main tools that are used here are things such as prior authorizations, step therapy, issues with regard to utilization review as a retrospective look at it, things that may be done with refill limits, maximum dollar limits, limits that have to deal with a quantity limit or a day supply limit. All of those try and restrict utilization to what presumably is an appropriate way to handle the drug or how the drug is supposed to be utilized. And if a claim or a prescription comes through the electronic adjudication and it is rejected, it's being rejected because it has hit one of these particular edits and is effectively addressed that there's something wrong, or at least it's being used as a sentinel, so that the sentinel says this particular one is going above that, so particularly maybe you want to look at that more carefully, maybe you want to review that particular claim more carefully or that patient more carefully to see why it is that they are going over the particular threshold that's been established. You can also, for example, in utilization, put in age limits and gender limits and things like that. And the general idea is a medication has been approved to be used in a particular kind of population, in a particular age group, and that those particular controls are what you're going to check against to make sure that everything is being done according to the product labeling, according to what information is available, or even current information that's available beyond the labeling. So if labeling hasn't kept up with use, then these controls can be placed into use. The question is do they work? When you deal with this in utilization and you do all these different kind of tests, does anything actually happen? The answer is it's frequently not. There's really two arguments to this, and we should be fair and objective in addressing it. One issue is that we throw all these controls, and hopefully in doing so, we stop inappropriate prescribing. And we ensure the fact that prescriptions have to go through in a given way. The pharmacy knows it, the physician knows it. Hopefully the patient will be informed of it and educated of it so these things can be stopped. The con argument is that they add a lot of noise, and that all of these prescriptions frequently have multiple rejects, and those rejects can come up and the pharmacy has to kind of work their way through, or as is known as cursoring their way through them, effectively saying okay, 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 so that these prescriptions can go through. When you do that, what you're identifying is that whatever is really important is getting lost in the broad noise of everything else. And what we want to make sure is that whatever is really important is not lost in that noise. That's usually the job of drug utilization review, to look at it retrospectively and to say what's going on. The real question that we all have to ask, and it's a fundamental question, is out of the total number of claims, how many of them hit a given edit? What's happening? Is it a big number, a small number? Is it 1%? Is it 5%? Usually the threshold is that if something is over 5%, then it's worthy of looking at. If it's less than 5%, it's not worthy of looking at. But that can be modified easily depending on what is important and what isn't. And you'd look at something important even if it was 1%. So our fundamental issue in how health plans and others look at utilization is to say, what is the result? What is the outcome? It's measurable. We can measure it in the claims. We can see what the differences are. And we can't just say, well, we have a particular number. We have to reconcile. We have to assure ourselves that that is the correct number and that we have appropriate documentation to demonstrate it. Or else we're spending a lot of time, a lot of money in trying to do this and effectively not getting a lot of result. I wish you a very good day, and I look forward to speaking to you again next time.